Hello, dear Chairman and dear ICS members. Good day. Today I'm going to present the topic, can we use urinary biomarkers to differentiate dysfunctional voiding from women with overactive bladder syndrome? Lower urinary tract symptoms include storage dysfunction and voiding dysfunction. The prevalence of overactive bladder is high in women with storage symptoms. Some of these patients present Detrusor overactivity (DO) with or without dysfunctional voiding (DV) during urodynamic studies. The management of DV is crucial in the management of DO because the presence of bladder outlet obstruction (BOO) could aggravate OAB symptoms. Although video urodynamic study provides accurate diagnosis, its utilization is limited by the invasive nature and the radiation exposure. The development of surrogate biomarkers is still lacking for female LUTS. Our aim is to investigate whether women of DO with or without DV have different urinary protein compositions that could become potential biomarkers. Women who visited our institute for the management of LUTS were included for the prospective study. Urine samples were collected before VUDS. Urinary proteins include AOHDG, PGE2, interleukin-1 beta, interleukin-2, 6, 8, and tumor necrosis factor alpha. These were quantified using ELISA kits. VUDS was performed under fluoroscopy and multi-channel urodynamic equipment. Patients with DO with or without DV were included for analysis. Patients who had SUI without bladder dysfunction were included as a control group. For statistical analysis, ANOVA was used to compare the three groups, including DO only, DO with DV, and the control group. Post-hoc analysis was done with t-test between each group. As you can see, we have 30 patients in patients with DO only, 24 for patients with DO and DV, and 20 patients in the control group. The VUDS parameters are all different between the study group, which means group 1 and group 2, and the control group. The p-value was the test for the ANOVA. And the study group generally have a higher detrusor pressure, a lower maximum flow rate, a lower voided value, and a larger post-voiding residual, a more sensitive bladder with a poor compliance, and especially for group 2 who had DO and DV, these patients had a significantly higher detrusor pressure compared to patients with DO only. As a result, the AG number was also significantly higher, indicating more severe obstruction in group 2. For the urinary biomarkers, most of the biomarkers were similar between the groups, except that the 8-OHDG was higher in the study group compared to the control group. On the contrary, the IL-2 was significantly lower in the study group. For your information, the 8-OHDG was a marker for oxidative stress. PGE2 was a marker for bladder contractility. The interleukins are markers for inflammation, and TNF-alpha for apoptosis. 8-OHDG and IL-2 were significantly different from the control group, indicating that DO is associated with increased bladder inflammation through the induction of reactive oxidative stress. The decrease in interleukin-2 could be the result of negative feedback in chronic inflammation. The inflammation could be either the cause of DO or the response to DO. 8-OHDG and IL-2 were not significantly different between DO patients with and without DV, indicating that transient sphincter dysfunction during voiding phase has limited effect on the inflammatory process in addition to DO itself. We concluded that RS-induced inflammation can be detected by urinary biomarkers in women with DO. The presence of DV does not alter the composition of urinary inflammatory proteins in women with DO. Thank you for your attention.